Very good. I'd ask the speakers to come up, those on the line to stay on the line, Dr. Youssef. And as we've gotten a little bit behind, one of the things that has happened is that that Paul I may have already stepped out, but has to leave to catch his flight.
So I'll final slide stop there. Can you hear me?
Yes, thank you.
Okay. I get very nervous, Dr. Stalling. I can't tell whether we're on or not.
Okay, well, I think we're doing well now. We did have the other remote presentation. So thank you all very much for an absolute amazing set of data and stories and study design information. What we'd like to do now is open this up again for the committee members to ask questions. And I'll encourage you very strongly to use the microphone because we've gotten a little bit of feedback that people are listening remotely couldn't hear the questions. And I don't want to take the time to have the questions repeated. So you have the job of doing it well from these front two rows. Who'd like to start? Questions? We need a mic here? That's right.
Actually, having two mics is probably a good thing. So it's really a two-part question, and it basically goes back to the pure study being an observational, non-randomized study, and then the study we just reviewed from Dr. Neal being the randomized study. And on one hand, we've got information that we know is not quote-unquote perfect as per a randomized controlled trial. I think, Dr. Youssef, you had mentioned earlier that you did propensity scores, you matched, or you did inverse probability, or you did covariate matching, you did something. But you still believe that a randomized controlled trial will work, or should be the way to go. And once you answer that, then I'll ask my question about the randomized.
The answer is yes. Wherever possible, we should do randomized trials, only if it's impossible. Okay, I agree, Dr. Wells, that randomized trials are the preferred methodology if we can do it. And as you know, my career is 80% randomized trials and 20% epidemiology. However, there are situations where this is not possible, and that's where you have to then think of alternatives like natural experiments, instrumental variable analyses. But in addition to propensity matching, we did another matching kind of analyses, and it just supported the data. Having said that, both at the high end and the low end, we're looking at hazard ratios of about 1.3. You know what? That's within the realms of confounding at both ends. So I have to just say that's our data. Would I like better data? Yes.
I was going to ask you about instrumental variables, but you already answered it. Because I think that some other, quasi-randomized or near-randomized.
Quasi-randomized.
So, Dr. Neal, my question to you, I followed you with great interest to see how you could do such a very large-scale study and make it work. And and I had a bunch of points, and as I was going along, you were taking them off one at a time. And so forth. So that was very nice to see. I was really happy for the fact that you were going to be looking at administrative data or regular, data that's collected for other purposes. Because what we're dealing with here, I assume, is a very large, simple, pragmatic trial, given the fact that your incident rate is going to be so low. My question is twofold. Number one, how long is the trial? Because some of these events are going to take a while to occur. And are you hoping to actually continue it beyond maybe your initial plans? And the second one is that you did assume, I won't talk about the interclass correlation coefficient being 0.04, but you did assume a 13% relative risk reduction. And I was wondering whether that was done for purposes of sample size, or was that done for purposes that you really think you're going to see that difference?
Yes, so thanks. So to the first question, the plan is to follow the participants for 5 years.
from the first from randomization, and we should be able to do that by about the end of 2019, beginning of 2020. And we believe that the mode of action which we're postulating, which is driven primarily through blood pressure reduction, should have plenty of time to act in that time frame on the primary outcome stroke and indeed on the secondary outcomes of total major cardiovascular events. In terms of the assumption about effect sizes, we looked pretty hard at the data and we tried to work out what we thought we could get in terms of a sodium reduction, what we thought that would drive in terms of a blood pressure reduction. And then there's a wealth of data about how a given difference in blood pressure is associated to a given difference in stroke risk that is both age-specific and sex-specific. And so we pretty carefully calculated back from that, and that was how we came up with our power calculation. Just finally, we are using routinely collected data. There are both pretty good national mortality surveillance system in China, which covers all of the provinces and counties that we're operating in. And there is also the new cooperative medical insurance scheme implemented in China, which covers more than 99% of all of the individuals in these areas. And we are currently using that to help us collect data. But to your point, we could potentially use that to continue to collect data after the randomized intervention, the initial trial is complete.
Thank you. Did you have a comment related to that?
I had a comment. I think Bruce, this has been his passion for years. He's done a terrific job. Let us hope the study is positive, in which case there'll still be two issues related to the United States or Canada. The levels of sodium in China are very different from the levels here. And as I've shown you, the epidemiology suggests very different results in China versus here. The second part of it is we'll never know whether it's sodium reduction or the potassium supplementation. Having said that, I would still say this is a terrific trial. Now, there are two other trials happening which you may know of. One is funded by the CIHR in Canada, led by Justin Ezekowitz from Edmonton.
I'm going to get you to pause there because right now most of the time is for the committee to come back. But if people, people probably do know of the other trials, but we can get that information.
Mentioning that because it's relevant.
Well, I think good. We'll pick that up. Other questions?
I have a couple of questions for Dr. Youssef. In your PURE study, this was a very large, very heterogeneous sample, and you had overnight samples on them. With a very size matters to some extent, but if there's biases, you could have a very tight confidence interval around a biased estimate, for example. How could you control for all the factors which were spread across your heterogeneous populations, like the income, things like poor nutrition, looking at different ways of ascertaining medical events, and all that stuff? It seemed like the list of confounders you adjusted for was not that large, especially given the number of events. So how confident are you that you don't have residual confounding?
We had close to 2 hours of data collection per person, including very detailed food frequency questionnaires, which Walt Willett had worked with us for the last 15 years to train us. So it's extremely detailed FFQs, the best you can use. They have limitations. And we published based on that in the Lancet 3 papers last year on fats and carbohydrates and other things. The second issue is everything that you can possibly think of, or most things, are collected, and we adjusted for them to the extent you can. I mean, you've heard me. I prefer randomized trials to epidemiology almost always. The last one is on adjudication. We had standardized definitions. Events were prospectively ascertained. Supporting documents were obtained. They were adjudicated by people in each country using standardized definitions. A random sample of those across the world were then brought into a central committee who then re-adjudicated to test the adjudicators. The amount of effort that has gone into standardizing this cohort is just enormous. Nancy, you're right. This is the best that can be done. I would still prefer a randomized trial to this huge effort we've done. All the sodium assessments were done in 3 core labs that were standardized across each other. So we know the sodium assessments were standardized. We know the dietary information was standardized. We know the events were adjudicated. So they were as extensive as is possible.
My other question has to do with your sodium measures. You presented a Blant-Altman plot comparing the overnights to the 24-hour. First question, those overnights, what was the relationship in timing to the 24-hour? Was it done right after the 24-hour?
Yeah, the 24 hours were collected. And at the end of it, a separate sample in the morning was peed. So we didn't take a sample out of the 24 hour. It was a separate sample.
Okay. In your Blant-Altman plot, it looks like there's a trend, a slope declining. The average bias is very small. It's about 300 milligrams a day. But it looks like for those with lower sodium excretions that your values are much higher, even as much as 2,000. I mean,
no, that's incorrect.
Your plot has a slope going down, so that the higher...
No. I think you've got it wrong. I don't know who drew that. Somebody has must have superimposed. Over 6 grams, there is what you say is true. Under 6 grams, is 0 or close to 0 bias.
Okay.
But whatever it is, you can adjust for the bias. If that is a concern, you can adjust for it.
Suggest then is when we're done, just at break, why don't you two look at that same slide together, because that would be important to clear up. Other questions? You go.
You see, even first, I don't agree with you that there is bias below 6 grams, but even if there is, you can mathematically adjust for it, and it won't change the shape of the curve. It may change the point at which you say it goes up, or risk goes up, or risk goes down. So the shape of the curve won't change.
Thank you.
I had two questions. One for Dr. Youssef. Because of the high correlation that we heard about this morning between sodium intake and caloric intake, how is that addressed in?
Actually, we didn't know that, so we haven't adjusted. Now that I heard it today, I'm going to go back and redo the analysis, and happy to share it with you. But when I think of, we did an analysis which we have never published so far, which is energy intake versus outcomes, and you get a J-shaped curve. So let us go and check it, and we'll come back to you.
So the question is whether you're just observing the U shape for the energy and not for the sodium. So,
I don't know
right. I'm going to do that next week. Right, but if it's highly correlated, it's very difficult to, tease out the difference.
Diet is the most difficult thing to analyze in epidemiology. I've done all kinds of epidemiology. This is the toughest one. That's why I prefer randomized trial, no matter how tough it is.
My second question is for Dr. McCarran, related to hypernatremia. And so that's serum sodium levels. To what extent is that actually caused by low sodium intake, or conversely, can it be ameliorated by higher sodium intake rather than? And when you go into the hospital, you get an IV, presumably to restore your electrolyte balance. So I guess that I'm a little unclear, just physiologically, the connection between hypernatremia and sodium intake per se, as opposed to other, morbidities that are causing you to, excrete sodium or some other thing that's leading to that hypernatremia.
Excellent question, and it's one that is best answered by some of the data that's out there. The 3 studies, they're not the only ones. There's a number in bone health that say the same thing, have been corrected for the kinds of confounders you would mention, like getting an IV. The physiology of maintaining your serum sodium is driven in large part by the relationship of water intake, sodium intake, osmolality. And this is fairly classic, renal physiology. You would expect that if you are significantly below some threshold, a lower sodium intake is going to present with a slightly or maybe dramatically lower serum sodium. Most part, a minimal reduction. That said, the Medea study from St. Elizabeth pointed out that, and Nick is, and Horacio knows Nick better than I do, and Nick is an exquisite investigator. They controlled for these factors, and the hyponatremia was there. It was made worse in the hospital if you came in. My advice as a clinician is, if you check into a hospital, probably the first number you should check is your serum sodium, and then talk to your family. That's meant to be.
I did. I'm the one.
But...
I'm the one of the doctors here. I'm laughing about that. I got the joke. Good.
All right. So you're asking. I think the randomized controlled data that was extracted from the Cochrane database certainly offers an insight. Healthy people brought into a randomized trial, put on, in many cases, a very low sodium diet. I accept that, and their serum sodiums went down, because all these studies had an entry serum sodium and one or more serum sodiums during the intervention. And some of the trials are good, some are not so good, but you see a pattern that's consistent. I think we need to be concerned about this. We can't walk from it. It's been seen in bone health. It's been seen in issues of the aging population. And these are some of the people who are following the advice of, lower your sodium intake.
Good. Thank you. Other questions? Yes, we have questions again from our committee members off-site. Thank you.
So this is for Dr. McCarran. Would you please comment on the influence of reverse causation on your statement about those with higher blood pressure eat less sodium?
Well, the observation from N. Haynes in the first N. Haynes study, and what Dr. Cogswell and colleagues at CDC has shown, you can correct for, particularly in the later N. Haynes, a tremendous amount of information. And the CDC data suggests that, as they publish it, that if you have high blood pressure, you're tending to eat a lower sodium intake. That's what the N. Haynes data that we published in Science in 1984, which I might add, some of you know, my main interest at the beginning was never sodium, it was calcium and mineral intake. And it is that slide that dragged me into this controversy. I believe the CDC data that was published 2 years ago. And people with high blood pressure are tending to eat less sodium. And that does raise a question. Why are we trying to lower their sodium intake when there's a trend that it's already lower? I don't know the answer to it, but we need to address that question and get it clear. And the evidence from 35 years ago says there is that trend, and it says it is so today in the more recent N. Haynes.
So just to follow up on this is Janan. So, what we were all thinking, all the nutritionists and physicians and nurse practitioners, is that was the reflection of effective treatment, that these people have diagnosed high blood pressure. They're being treated. Part of that treatment is almost the universal message of eat less salt. So I agree, and I don't know the data set, but some people here do, and we may be able to look more into that on the committee level, because I assume it's a relatively small number of people making up that data point. But I agree that's one of the hardest parts, because depending on where your bias is, on the clinical side, it looks like, well, good, maybe we're doing some good with the current standard of care. And on the epi side, it's look what's traveling together, low dietary intake and low blood pressure. I think we have other questions.
So this one is for Dr. Youssef. In your observational studies of sodium and blood pressure, please comment on the achieved blood pressure of those who received active treatment.
I didn't present anything related. Are you sure it's to me?
Then perhaps that's the wrong person. I apologize.
Well, why don't we recycle that and see if we can get
Yeah.
clarification? Do you have a third question?
Anybody else have?
Because I didn't do randomized trials.
Back to the committee
wish
in
I did.
attendance. Any other questions? Okay.
So I think
Sorry.
I have the right person this time. This one's for Dr. Neal. The clinical trial you are conducting is excluding persons if themselves or their family members have severe renal disease. How is that defined? How strong is the relationship with dietary potassium intake with higher serum potassium concentrations in the general population and in persons with kidney disease?
Yeah, so good question. So the exclusion criteria used in the trial were that there's a known diagnosis of serious kidney disease, which would be based on a prior consultation or diagnosis of either the index case or the family member with a local physician. So we didn't test. We didn't have the resources to test kidney function in all of our participants and their family members. It's important to note that excess potassium intake is only a risk when renal impairment is really severe, and so this was felt by the trial steering committee and the ethics committee to review the project to be a reasonable approach to take. So I'm not going to be able to tell you the renal function of every individual participant at the end of the study, unfortunately. What we will be able to tell you just refers back to a comment that Salim made regarding the sodium intake levels, is we do know the sodium intake levels for the people who are in the trial, and they are between 10 and 11 grams of salt a day, or about 4 and a bit grams of sodium. So we should be able to address questions about that nadir on those pure plots. So if those pure plots are indeed correct, we ought to be causing no benefit or even harm in this patient population. So I think in that regard, the study will provide some really interesting data.
Bruce, let me just clarify that. So the history of renal disease is not participant self-reported. It's coming from a medical record, the regional physician.
It will be participant self-reported based upon their prior consultation with a physician. Participants were recruited with the assistance of the local village doctors in each of the villages who are participating in the trial. So they have pretty good insight into the medical history, but ultimately the data was collected directly from the participant.
Good, thank you. Do you have another question, Megan? Maybe. Anyone else have a question? Well, then let me say this again has been a simply great session. Thanks to all the speakers. Thanks to all of you. We have a well-deserved about 15-minute break. Get up and stretch and come back because we have another presentation, and we also have the part of the workshop that is testimony from other interested parties. So we'll have that as well. Thank you.